Good afternoon. I'd like to welcome you to session 350, Cultural Intelligence, the Conduit to Bias Management and Health Equity. This is our last session, and we're very excited that you're all with us, both virtually and here at the conference. My name is Vonette Fay, and I am a professor of nursing at the Sussex School of Nursing at UT Houston. And so we want to thank the people that are in the virtual audience. I think there's about 70 of you, and so we're real excited that you're here. There is a way that you can connect with the live and virtual by going to and participate in polling questions. I understand you have a couple polling questions. So please visit gapna.org/live from your mobile device. I've got some housekeeping things, but I think by now, most of us are very aware of all of our housekeeping, and so I really won't go into those. I want to give Dr. Richard Eglin time for her presentation, but your professional contact hours are not earned until you complete your evaluation, excuse me. And so I'd like to introduce Dr. Angela Richard Eglin. She is the Associate Dean for Equity at Yale School of Nursing. She has been a registered nurse for over 27 years and a board-certified FNP for 20 years. Her clinical practice experience includes primary care women's health, urgent care, disaster response, and veterans health. Please welcome Dr. Richard Eglin.
Thank you. So I started doing this work in 2019. I've always considered myself a strong patient advocate. It's what I teach my students, that's our first role. So with that, I started doing this to try to convince all of us to make advocacy our primary role so we can move toward advancing health equity. So my talk today is on how to use cultural intelligence as a conduit to bias management and health equity. I don't have any disclosures. And our objectives for today are to critically appraise the origin and impact of bias on health outcomes, discuss and apply cultural values, preferences to bias management, discuss the significance and impact of self-assessment and emotional intelligence and cultural intelligence on bias management and mitigation of biased influence outcomes, and to apply cultural intelligence principles and bias management strategies to mitigation of biased influence decisions. So for people who've printed my slides, we submitted those early on, so some of it will be different, and I will make sure I give them the updated version for you. So whenever I do these talks, I do like to start with a warning, because we know when we start talking about things like discrimination, oppression, and race, it can induce some feelings of discomfort. So I always like to use analogies. This is a process. It is a lifelong journey. So just like when we're on a plane, we can't avoid turbulence to get to where we're trying to go. The difference is we don't have a final destination with this, because transformation is ongoing. So I do invite you to lean into that discomfort, because discomfort is where improvement begins. So fasten your seatbelts, the transformation is happening. And you'll see we're being held accountable by multiple professional organizations. But I'm going to start off with letting you know how perspective matters. And that's the way we're able to tap into the fact that every living human being has biases. So I typically like to liken this to therapy. And so if people go to AA, we know the first thing is admitting, right? So I'm Angela, and I have biases. The thing about it is we should not let those biases impact the way we interact with people. So perspective definitely matters, and it comes from our lived experiences. This is not a real patient. This came from Creative Commons, but a 64-year-old African-American patient was admitted 3 days ago for evaluation of generalized severe pain. The patient calls for pain medicine and rates the pain at 10 out of 10, looking just like this. The patient is not showing any signs of pain when you enter the room, and she's prescribed Tylenol 3 every 4 hours and calls for it every 4 hours. So looking at this patient, and this is for you to do internally, what are your assumptions? Based on that scenario, what do you assume about the level of pain, and what were your initial feelings about the patient when you first just read this information? So those are the kinds of ways you tap into those biases and how we can control the biases if we're able to go ahead and own that we have them. So when we talk about cultural intelligence or CQ, bias and health equity, some people really don't care, and it's disheartening, especially when health professionals don't care, because you need to care. So it's your professional, ethical, legal, and moral responsibility to care, and we all our practices should be guided by certain virtues. Respect, ethics, honesty, and integrity are some of those virtues. And tapping into that is also important in terms of moving this forward. So I'm going to show you a video. I think I can do it from here. Oops, nope. Do you have to do that? Press, it's on the slide at the bottom. Press play. There we go.
So in healthcare, bias comes in various forms. And I would say there's 3 primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations, how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the U.S. economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
So I wish that video had played correctly, but basically the main points are there's research to support that a real horrible numbers, and I'm going to talk about a little bit of that, but in terms of pain management and some myths that are out there about African American people not having as many pain receptors or whatever those myths are, but just knowing that all human beings are built the same way. That's the takeaway from that part. And then when we talk about in terms of healthcare organizations, the second point that was made in this video was the lack of ability for promotion, not allowing people of color to work in certain departments. And guess what? I experienced that, and it's still going on today, and it's horrifying. So we have the opportunity for those people who are leaders in the room to mentor and promote people based on qualifications. And then the third thing, $310 billion on costs, wasted costs, just based on racial bias. Imagine all the other biases, which I will talk about with another study that was done in 2019. So what is bias? We kind of all already know. It's either intentional. Sometimes we know exactly what we're doing to people based on biases, and sometimes it's unintentional because, again, it's experienced through what we were taught and assumptions from the time we were born. So it influences how we behave with other people. It occurs because of our human conditioning, as I just said, and it often results in unfair and inaccurate judgments, overlooked talent, discrimination, and the worst part is the poor and detrimental health outcomes and inequities, as we're seeing right now with COVID. And it perpetuates health disparities when we don't acknowledge and accept that these things are really happening. So this is the study I was talking about. It was a systematic review of several studies that were already out there, because there's already, as I said, ample evidence to support that bias in patient care leads to mistrust and also some detrimental health outcomes. And in this study, they wanted to look at intersectionality of other domains of social identity and how they affect the way we deliver health care. So these are the things they looked at: race and social class, mental illness, weight, race and sexual orientation alone, and anti-aging. And I can say it's quite disturbing. One of the things they found with racial and ethnicity bias is that certain diseases are stereotyped toward Black people. You automatically think it must be this because the person is Black. Unfortunately, I'm here to say I've experienced that as well. So I'm not just talking from what I read, I'm talking from what I live. Then when we talk about weight and anti-fat bias is how they labeled this. I don't have a problem with the anti-fat thing, but one of the things it shows, even health providers who work in bariatric medicine admitted that they have biases toward those patients and label them as lazy, stupid, and worthless. In terms of the sexual orientation, about half of the respondents had some explicit bias, and 81.5% expressed implicit bias against gay and lesbian individuals, and it doesn't even cover trans patients. Then anti-aging bias, 90% showed a preference for treatment of younger people versus older people. And female medical students, I'm happy to say that, at least somebody's listening, but they did say they were less ageist, and had less anti-aging bias and a higher motivation to care for the elderly population. So I talked about these organizations, professional organizations, as well as accrediting bodies who are now holding us accountable for moving forward in terms of addressing biases and isms in healthcare. So this just came out in 2021 from AAN, American Academy of Nursing. And there was a conversation about health equity and racism. The key takeaways in the summary report: racism is a social determinant of health. People are still denying that racism exists, so it's critical that we acknowledge and own, those of us who know that it's real, and I don't mean just Black people, all people who know that structural racism is a real thing that has led to health inequities, need to be the ones pushing this work forward, because we should have all gone into this profession to serve others and for the health of other people, for the outcomes of other people to be optimal, no matter what you look like, no matter what your sexual orientation is. Diversity and inclusion advance equity and help organizations to thrive. So I want to throw in the belonging piece too. So DEIB normalizes multicultural existence, and it creates a sense of global citizenship, which is what we should all be thinking about when, as I talk about cultural intelligence, you'll see where I'm going with this better. Many characteristics of diversity are invisible. So you heard Mr. Gupta in the video a little bit talk about trust and how important that is. So if a patient doesn't trust you, they won't reveal some of those invisible things that support their health care. Nurses need to critically examine how they relate to the populations they serve. So again, if you know you have a bias against someone, you need to own that and acknowledge that bias, because that is the only way that you'll be able to kind of stop yourself from applying that bias. We'll talk about that a little bit more, but look at how they're showing up and how they may impact healthcare on the other side of that if you allow them to influence the way you interact with people. And nurses are committed to taking steps to ensure a less racist future, but to do so, we must move beyond words to action. And anybody who knows me knows I've been talking about that for a long time, way before what happened in 2020. And I'm tired of talking about it, so I'm promoting that. It's time to start doing something about it, so I'm really happy we're being held accountable from the organizational perspective.